Well, this is our first lecture on epidemiology, and I'm really happy to bring it to you. And I think you'll just find that there's a lot of interesting elements as we go along. And I will try and make them as exciting as I possibly can and make them memorable so your study is quicker and easier. Um, I really think that this particular quote um, sets into place what we really mean by epidemiology, and I just like to share it with you because we think of Martin Luther King often, and he's been a man that's had a significant influence on our society. And I'm going to read this to you, and but it goes, we are caught in an inescapable network of mutuality, tied in a single garment of destiny, and whatever affects one directly affects us all indirectly. Now, there are really there are some underlying assumptions in this statement based on its author. And I just like to cover a few of them so that you see how they connect to public health. First, that culture and diversity play a role in health, often a major role, and and are influenced by access to care, health literacy, and a wide variety of demographic variables that aren't mentioned there. And that there are three levels of maturity, and we talk about this generally from the child development area as dependence, independence, and interdependence. And King's definition focuses on interdependence. Um, it's not about me, it's about us. And this has great implications for the spread of disease. We must realize that the behaviors of one often influence the behaviors of many. And so we are all really connected, especially on the disease realm, but in so many other ways. I'd like to share with you about heart disease, and this is a way to get you to think about maybe how we're interconnected, and it's going to emphasize a lot of the principles of epidemiology about a target population, etc., and how we focus our attention in epidemiology. And this is having to do with those basic principles that we talked about, um, those basic principles and objectives that we talked about in the syllabus. So let me ask you one question. As you look at this, we're talking about U.S. heart disease rates for blacks, ages 35 and older, by county. And but let's just look at the map overall, because this is part of what you're going to be doing when you're looking at epidemiology, and so this is a good place to start. If I were going to ask you a question, what's going on in the gray area? Which is a color code? It's a color code that indicates what? It indicates, in this particular instance, if we look at the schedule, it looks at uh, insufficient data. So we don't have enough data to tell about um, obesity, or excuse me, heart disease death rates in the country in these in all these areas where it's gray. They aren't sufficient enough. And but we can make some other um, conclusions or draw some other tentative conclusions. We can assume that by looking at this, that in some cases blacks live in populated areas, And if we look at New York over here, that would be a populated area. And if we look at Florida, we can see that the tip of Florida, which is interesting relative to the other parts of the map, that um, there's a lot of heart disease here in the southern part of Florida. We can also note that the highest prevalence rates are by state. And as we go across, we can look at um, uh, Mississippi and Tennessee, and let's see, where have I lost Oklahoma? Um, and when you look at Oklahoma here, it's heavily concentrated with this dark red color or the dark gray color, depending on what slides you have. And we also notice when we look at Indiana, which is obviously close to home for us, that Fort Wayne, there seems to be a concentration of blacks and heart disease death rates there. And we look further down on our map and we see that Louisville has a concentration of heart disease deaths. Um, and this underscores one of Martin Luther King's tenets about cultures and customs. And so we have some cultures and customs probably that are more prevalent in this area of the world than in other areas of our country, and especially in terms of the West Coast. Um, you can see that we could probably at least conclude um, tentatively that there might be a difference in lifestyle in some of these places, and especially in eating habits and in physical activity. And one thing that we have noted about many of these areas of the country is that they have a higher concentration of fat in their food. And I know that people have joked that if you don't have gravy over everything, it's really not an edible meal. So a high fat diet could have an influence, and that could also be expressed by various cultures and um, people learning a particular style of eating early on. So these are just some of the observations that we are making where we are inescapably connected, and culture and society ties us together in various ways, and where practices become routine and standard and acceptable, and we really don't know much difference because this is the way that it's been done for years. And I forgot to mention Texas here, but you can also see that Texas has some behaviors that would have more heart disease. So I hope that that definition sort of links things together in your own mind. Now, I'd like to cover, because people always ask, uh, I get asked all the time, what is epidemiology? And I've come up with a simplified answer. I say, well, we study disease and death, and we set priorities for the nation as to what it is that we're going to concentrate on, which sounds like a good answer, but it's not very accurate. And I'll explain more about that because politics and social science play a role in disease as well. But the key words that I mentioned earlier in the first lecture that we want to focus on is distribution, determinants, frequency, injury, and disability. And if you want to underscore, in human populations. Now, let me just read it to you slowly. And this is a definition that you ought to commit to memory. And if we were meeting on a one-to-one basis, what I would do is I would have you recite this definition as a class out loud to see whether or not that you could do so and really understood the key terms. So again, I want to emphasize that this is by no means the only definition of epidemiology, but it's a study of the distribution and determinants of disease frequency and injury and disability in human populations. So I emphasize the and so that maybe that will aid you in memorization. Now, when you look at it, demos, we're looking at people. So it says human population. So that means right away we're looking at people, and the primary focus is people, and I often say noses. And it really has to do with the counting of noses. And so we're really studying people and not rats. Now, it doesn't mean that we don't use research from lower organisms to help inform epidemiology, but the primary focus of epidemiology, like many of the social sciences, the main thrust is on people. And so I don't want you to get confused and think that there's any other focus. I should say that the primary focus is people and not lower organisms. So more specifically, we focus on human populations. And when we look at, if somebody says, well, what is epidemiology? I often tell another story about it and say epidemiology is life because it's connected to all elements of life, and you will see that it has so many implications if you look at the life course and a life process. So if you'll just keep that in mind, and we'll go through and I'll peel each one of these terms: distribution, determinants, frequency, and injury and disability in human populations like an onion. So we'll just look at them very carefully and precisely so that you have a good idea. This should give you a whole lot of information about epidemiology all by itself. Now, when I continue to look at the next slide before we get on to those key terms, people say, well, what do you do with it? And really what we're talking about, we want to look at the origin of disease and what causes it. And there's all kinds of words we use to talk about etiology. We talk about determinants. We talk about agents of disease. Those are all the necessary causes of disease, or an agent is something that carries a disease. And so when we think about it, that's what we're after. If we can look at the etiology or the origin of something, we can do something else, and that's on the bottom line: to prevent, protect, and control diseases. Now, if somebody says to you, well, what's the major focus of epidemiology? What are you trying to do? We used to say we wanted to prevent and control diseases. More recently, the word protect has been added. Okay? Then also what we're trying to do, once we can identify, like the map I just showed you, various areas of the country, where we have more um, heart disease amongst blacks, we would focus on that part of the country because we know we don't have enough money and resources to focus on all parts of the country. And if in a certain part of the country doesn't have a problem, it wouldn't be prudent to focus there. But what we're going to do is use this information to help us um, design, uh, develop, and implement health initiatives, services, and programs. Now, I'm showing you one method here, and I will talk about others as we go along. I'm talking about policies because often policies are not thought of as being a part of public health or a way to change behavior on a population basis. And you can see that we have policies that have been implemented to have an impact on smoking, the number one area of preventable disease, and seatbelt laws. And you'll see why we're going to focus on seatbelt laws, because we're going to find out that injury is so important. And maybe I'll surprise you a little bit about which problems are the most important in terms of those that you think about most routinely. Okay, so are we together so far about a few applications? I hope so. Now, as I mentioned, we're going to talk about core competencies, and we told you that the course was put together thoughtfully, and it's not, the content is dictated by the associations of schools of public health. So if you have this course, you can claim that it's pretty consistent with any course you would have in most institutions in epidemiology. And we're going to talk about key terms where we can learn so much about a problem in and of itself, that we're going to talk about magnitude, we're going to talk about person, we're going to talk about place and time. Okay, so just hang on to your seats here and we'll get started with this. Now, you notice that the first term in the definition that we focused on was distribution of disease. So these terms have to do with looking at distribution of disease. And the majority of terms that we're going to focus on in the first few slides are going to have to deal with that primary term coming out of that classic definition of epidemiology that has to do with distribution. Okay? So when we talk about a person variable, we're trying to identify characteristics that have an influence on the etiology of the disease, such as those things related to demographic variables as age, gender, race, socioeconomic status, marital status, religious preference, devoutness, etc., etc. Okay? Now, place means just what it is, a specific geographic location. And if you remember that map that we looked at specific geographic locations across the United States where heart disease um, was highest amongst blacks. And then we didn't focus on the time period, but I could have, and I probably should have, to help you understand that the time frame that we were looking at. I know it was multiple years. I think it was from 1996 to 2000. So we've got a trend that's going on because we've looked at 96, 97, 98, 99, 2000. We've got 5 years of data that make up that slide.
Just get starting and we'll go and editing.
Okay, so I hope is what I've done so far is I've taken terms, I've given you an example about heart disease, and I'm beginning to make application, and I'm going to make further application by showing you this next slide. And this says, and we're looking at the person, um, uh, place, and time variables here. And so if I was going to give you a map, and we're talking about avian flu or bird flu, however you want to address it, doesn't matter to me about the formality. So we know these are individuals that have contracted the avian flu, and so we look in at where this concentration has occurred and is highest. And so we look at the various places, and if you're looking at the map, you can see that primarily we've got a place in Africa. I think this is Turkey, Iraq, um, and the tip of Russia, and in Indonesia. So this would give us an idea, um, and of course this occurred in 2007. Okay. What I'd like to do is quickly talk about the application of these variables, person, place, and time. And what we're looking at is avian flu or bird flu, and what you'll see is with the gold area, this is domesticated and wild birds that cover the continent of Europe. And we also, these little yellow pockets have to do with the wild birds, but we can see that where the most cases exist are designated by the red dot. And if my geography is correct, we have Africa, Turkey, Iraq, um, Thailand, I believe the tip of Russia. We have Indonesia and Malaysia. So if we were going to develop and implement a program just based on this information alone, these would be the person variables or the demographic variables that would help us locate the determinant or identify the determinant based on distribution, because this distribution helps us to decide where we're going to concentrate our efforts. All right? So, and if I was going to ask you what organization would be involved, you'd quickly say, well, is it the Centers for Disease Control? Well, no, it wouldn't be, because this is a world problem, so it'd be the World Health Organization or the WHO. Now, I'd like to show you this particular map or or this particular graphic. I've always found it fascinating, and you can take a moment and look and see what we're looking at. I think it's a interesting title of the article, Nutrition and Health from Womb to Tomb, but this is looking at the estimation of dietary um, fat intake in grams per person per day, and it's looking at breast cancer death rates. And if you we know a couple things in terms about the person variables, that breast cancer occurs in 10% of men, and about that would be the cases that would get it, and 90% of women would be, or we would have female cases. So when we're looking at this, we're looking at female cases, we think, not identified, so that person would be female uh, breast cancer patients, and we're looking at these worldwide, and so that would be the place or countries we could call as countries and regions of the world, right? And we can see that as fat intake goes up, breast cancer also increases, and we can see that the U.S. Has a high-fat diet, and the number of breast cancer cases is greater there than in those cultures that do not consume as much fat in their diet. So we've learned now the time. We haven't really talked about that, have we? We talked about the places being the countries and the regions of the world, um, and we really haven't talked about time. We assume, well, gee whiz, now where would we find time? Oh, here it is. It has to do with the article itself, and probably it would be before 1996, and we don't know any more information than that. The reason it be before 1996 is because it takes so long for information to get published. Usually there's a couple of year delay in some journals. So when you look at this, the time variable we could predict, because we don't know. We could go back to the original source to be accurate, but we would just say probably, uh, 1992 to 1994. Okay, so person again is women with breast cancer, place in all regions of the world, and time we think is possibly 1992 to 1994. Now let me ask you one other question. What would explain this relationship? Is there anything that you know of from your background and basic statistics that would explain the relationship between um, uh, breast cancer and dietary intake? Well, what we would call it would be a least squares regression line, because a straight line seems to be the best explanation of this relationship. And so I would expect you over time to be able to look at those kinds of trends so that you would be able to describe them in a statistical form, or you might call it a quote a linear line or a straight line that would cut through and summarize that data. Okay, this is an interesting graphic. It looks at who, where, and when. So who is person, where is place, and when is time. So if you want to use those as synonyms for the words that we use as person, place, and time, that's appropriate, but it's not professional, it's not preferred, and it's not often used. But nevertheless, I wanted to point that out to you, that you could do that. So Now, we're talking about fluoridation here, um, and we're talking about DMF, decayed, missing, and false teeth. And we're seeing that there was a trend that happened in New Zealand. So if we ask um, who, who are we concentrating on? We're concentrating on those with DMF. Where? We're concentrating on New Zealand. When? We're concentrating from 1970 to 1984. Now, and the result was when fluoride was added to water, that we had fewer DMF, or decayed, missing, and false teeth. So this is a negative linear line, or least squares regression line, that explains that data. Now, our policies about the inclusion, now see, we're starting to interpret this and get into what it means. And our policies about the inclusion of fluoride universal? Does every place in the world have the same policies? Well, you know that isn't the case. We know in Swansea, Wales, for example, they don't have any fluoride in the water, and they don't want the government telling the populace that that's necessary or they should do it, so they have to make an individual decision or choice to provide fluoride to their children. Then the next question I would ask of you is, does everybody require fluoride? Well, no, everybody doesn't benefit from fluoride. There's a critical period, it seems, in the development of young people that fluoride has should be included in drinking water, and that's roughly from the time of birth to about the time of full maturity of an individual, which is 24 to 25 years of age. And the next question I would have is, oh, well, if not everybody requires it, how come we're having everybody consume it? Because you know that everybody across the age span consumes it in the United States. So, um, and I think I asked the question about, is fluoride expensive? The answer is yes. And I would also pose to you whether everybody is in favor of using fluoride, um, or are there numbers of people who are against it. And there's nearly 3 million people who have voted against the use of fluoride. So it's a controversial issue at the very best, and as an educated person, you'll be forced to read the literature and make decisions for yourself as to whether or not you would recommend fluoride. But you must be informed. And I want to leave you with one other fact. Anytime you see brown teeth, like in Texas, that means that somebody's getting over 4 parts per million of fluoride, which discolors their teeth. So in Texas, fluoride occurs naturally in water, and this is the end result. Now, let me also quickly add that that doesn't make their teeth weaker. They usually have strong teeth and a few decayed, missing, and false teeth. Okay, so we've done a lot of interpreting just by looking at the who, where, and when variables that fall under distribution. Okay, Fluoride National Fluoridation Report. I want you to see this. You can see the heavier concentrations of fluoridation. The lightest color is through the darkest, and in the darkest, about 75 to 100% of the population are receiving fluoride. In the orange, it's 50 to 70 4%. In the lightest color, it's 25 to 49%. So if I was going to say to you, roughly those states east of the Mississippi River have the highest concentrations of fluoride in the water. Western states seem to have less. Well, that's an interesting epidemiological issue in itself. How come that goes on? Why did they make this kind of choice and decision? And of course, that would be an excellent research. So, what I've done here is I've used descriptive epidemiology. I've just described the circumstance, hoping to develop hypotheses by looking at distribution and the three terms under distribution: person, place, and time, and look how much information and the number of issues it's brought to light. Okay? So, um, this will be an interesting question to find the answer to as to why some think it's more important, some states and territories think it's more important than others. Okay, now notice I'm still hung up on the word distribution in that definition. And what's difficult about this area is everything's a demic, and anytime you have words that sort of sound the same, they get much more difficult to learn. So we have number two is an endemic, so you can see the endings, and then we have hyperendemic, and then we have holioendemic, and then we have epidemic and pandemic. So we have a lot of demics, and I can remember my father. In his later years, he was an engineer, and he says, all I do is go to ologists. He says, I don't know one ologist from another. I don't know, I go to a radiologist, I go to a cardiologist, etc., etc. So I think this makes it a little more tricky to learn. But my point here is that these are all terms, just like person, place, and time, that fall under distribution. That's the first term in the definition of epidemiology. Okay. Now, the first term that has to do with distribution is sporadic, and you can read the definition for yourself, and you've seen information in medical practice or in other environments that are displayed as such. But I have a question for you. How many think that we can make sense out of sporadic data? Well, the truth is that we can. And this is where we combine epidemiology and biostatistics. And if you were going to major in an area of epidemiology or concentration in epidemiology, we would call it epidemiology and biostatistics, and that's why they combine these. And we have a program called a time series analysis, because this is a time series. It's plotted information over time. Okay, so it's a time series, and through a time series program, we can usually make sense out of this and what it might mean, and so we could predict the future. So a time series means that it involves time and a pattern and the ability to make sense out of it. But the key thing that I want you to get from it is this is sporadic. And data sometimes in epidemiology presents itself in a sporadic form. Now I want to talk about endemic. And these are very important concepts and ideas, still falling under the general term distribution. What diseases do you think might be endemic? And What we mean is that's the steady state. They're pretty regular in our country. They don't change a lot. And every now and again they do, but just sort of go along with me and humor me here. We could say, well, polio might be a good example where the disease is pretty steady, or German measles, um, uh, and sometimes TB. But what has happened is, as the diseases are less prominent in our society, people quit taking injections, so the diseases that were once eradicated or stopped come back. And so endemic doesn't always apply to some of those diseases. So if we if we give injections for these diseases, we generally don't have a problem. There are 27 diseases for which we have vaccinations, and we have vaccinations for anthrax, cervical cancer, some forms, cholera, chickenpox, diphtheria, German measles or rubella as you know it, hepatitis A and B, influenza, Japanese encephalitis, Lyme disease, measles, mumps, pertussis, plague, pneumonia, polio, rabies, smallpox, Rocky Mountains, spotted fever, tetanus, tuberculosis, typhoid fever, typhus, whooping cough, and yellow fever. And of course, we're working on one for N9H7, and we have somebody here at Purdue that's trying to develop a vaccination for this new type of flu, and others that will occur from that flu. All right, so still distribution. Okay, so we're looking at distribution again. All right, and when we say something is hyper-endemic, it occurs at a high rate, right? It's a disease as a high incidence or prevalence rate. And can you think of a disease that would be hyperendemic? Probably the most classic that come to mind is AIDS and HIV. And when we think about HIV, we still have 1 in 9 million people worldwide who contract AIDS daily. That's an amazing number, isn't it? So if we're talking about 1 million, we're talking about actually it's 1,178,350 adults and adolescents. About 7% were living with HIV infection in the United States at the end of 2008. And that's the most recent year for which we have national prevalence estimates. But I just thought that might be of interest to you. Still looking at distribution, right? We haven't changed. Now, here's diseases that are hyperendemic, okay, that are occurring in high rates. And here's another one that's malaria. And if you applied person, place, and time, which I would encourage you to do, I'm not going to do it because of the length of the time of the lecture, but you could look at the person variables and you could see where you would be wanting, what population you'd be and location that you would want to target, and then you'd have to be thinking of some type of intervention. And again, this is a World Health Program because it is influencing the world, and we'll use terms to describe those. Now, holioendemic, and I want to show you this in a couple of different ways. I just want to show it in the same way. This graphic indicates this is a disease. This first graphic down here that looks at number of cases and age shows that the disease occurs amongst children. Okay? These two show the same thing. The children have the disease more often than adults. And that's what we mean by, did I say hyperendemic? If I did, I meant holioendemic, because holioendemic refers to kids. So these are generally diseases that do not, you heard the word generally, do not infect adults. Okay, now I want to talk about a foodborne outbreak. I know I've talked about distribution, and but I'm going to introduce some other terms that are going to deal with distribution, and so I have to take a tangent here. And when we talk about a foodborne outbreak, um, we talk about a restricted event, and it has you'll see right here that it is not a pandemic or it's not an epidemic. And so those are terms that you think you might know, but we'll make certain that you do. But outbreaks are confined to a small geographic location, and we got a list here. They're restricted to restaurants, schools, hotels, single buildings, or a small geographic area. And the most common one that you've heard about is Legionnaire's disease, and I'll talk a little bit more about that in a minute. Now, the CDC has specific criteria. The Centers for Disease Control, and I mentioned the headquarters in Atlanta, the closest one to us is in Chicago. And when we look at a food outbreak, it's 2 or more cases. And the first case is the endemic state. So we said the endemic, in other words, for endemic, is the baseline state that is usually, it could be high or low, but generally it's low and it's constant over time, and usually caused by exposure to pathogens, and it can have to do with a waterborne disease. As you notice in number 2, we talk about foodborne and we talk about waterborne. And Legionnaire's disease was a waterborne disease, and it occurred in a hotel in Pennsylvania due to warm water temperatures, stagnation, scale and sediment, and low biocide levels, and it was in the ventilation system. And we had, I can't remember, I think there was 242, don't hold me to that number, of people that got sick, and several of them died. So again, if we're talking about an outbreak, it is restricted to a small geographic area. It usually has a criterion, in this case 2 or more, and I've just talked about waterborne and foodborne, but we also have disease-borne, or we have diseases that would be considered only as an outbreak. Okay? Next, I want to give you an example of a disease outbreak, and this has to do with SARS, and you can see that this outbreak didn't occur until May 1, and it ran through predominantly the entire month of May. And you can see that who got it: healthcare workers, hospital patients, and hospital visitors. And if we were looking at person and place and time, it's talking about April 15th through June 9th, but this is the main area that we're going to concentrate on in terms of SARS, and you know that to be a severe acute respiratory syndrome, and it is a serious form of pneumonia, right? So we're looking at the outbreak in this, where does it say? In Toronto, Canada, in a hospital. We can assume it's in a hospital. So it's in a single restricted small geographic area. And this is a good example of an outbreak. Now, I want to talk about epidemic. An epidemic, now this is really important to note because now we're dealing with geographic area. We're still under the word distribution, and it has to do with the observed number of disease cases being higher than the expected number. Well, the expected number down here is the endemic, and you can see that the endemic state would be like the constant state or the steady state, and then all of a sudden we have a peak and it comes down back to the endemic state. So this is an epidemic as long as it covers a community, a state, or a region. So these are key terms in understanding an epidemic. When you talk about an outbreak, it occurred in a specific location. Okay? And so we see a break or a change in trend when we look at an epidemic, and we notice the same thing when we look at an outbreak. And if we went back a slide, we would notice that too. Okay? But this is the geographic region that we're focusing on here. Now let me give you another one. Okay? Here's a pandemic. All right? And pandemic has to do with a country, a continent, or the world. So that's what you want to focus on. And you can see that the expected or the endemic, the observed, is greater than the endemic state, still part of the definition, still part of the definition of an outbreak, an epidemic, and a pandemic. And this shows country 1 and this shows country 2. So the pandemic would be occurring in country 2, and country 1 would not be influenced. So there's a couple of ways of showing it, and that's all I'm trying to get across here. Okay? Now, let me show you. See, this is a mislabeling, and I'm trying to get that across. So, and we see this all the time in the news media, here amongst professionals. It says an epidemic occurring over wide geographic area and affecting large portions of the population. And 1919 influenza pandemic infected over 50% of the world's population and killed more than 20 million. So it's by no means restricted to a county or a region or some area of that sort. It's worldwide, and that's what makes it a pandemic. And I want to make a few other comments as you see this slide here. And you'll notice the crudeness of all the hospital camps that were developed because they were overwhelmed with people. But it's been noted in the American Medical Association, the Journal of American Medical Association, JAMA, in 1918. They said the year 1918 has gone, a year of a momentous as the termination of the most cruel war in the annals of the human race, a year which marked the end, at least for a time, of man's destruction of man. Unfortunately, a year in which developed a most fatal infectious disease causing the deaths of hundreds of thousands of human beings. Medical science for 4.5 years devoted itself to putting men on the firing line and keeping them there. Now it must turn with its whole might to combating the greatest enemy of all, infectious disease. They were talking about World War I there, of course, and oftentimes infectious disease in the history of our world have caused far more deaths than any war. Okay, this shows deaths in major cities in terms of this pandemic. You can see that we have New York and in London and Paris and Berlin. You can just follow the lines and you can see when the heaviest concentration of the disease. And this would, of course, make it a pandemic, and they do have it correctly labeled. And I just wanted to point that out to you. Um, of course, notice that the death rate was highest per thousand in October and November, and again began to recur in London during February. And why is it a pandemic? Because it's worldwide. Okay, so this will give you a little visual of the difference between an outbreak and an epidemic and a pandemic, and maybe that will help you to understand each. And then maybe you can go ahead and also label those and use those as a test about what would go in it to help differentiate it, and what are the factors or characteristics that differentiate each of those terms. Now, notice here is that all broken down to you for you. An outbreak is localized, it's two or more cases when foodborne and waterborne. There are no criteria for other kinds of diseases that aren't foodborne or waterborne. But again, the major factor there, if you had influenza, would be localized, and the observed would be greater than the expected. In epidemic, you have a community, a state, a region, and the number of observed cases are greater than expected. The pandemic is the same thing, but the geographic area changes, and you can see we're under all of the word distribution. In each case, we're looking at different distributions. Okay, so we really just are looking at this first word in in the definition of epidemiology. Now, I want to talk to you just briefly because people think that these words are used correctly. And this is talking about a large multi-state outbreak of infection, and these phrases are coming from the CDC. And when I talk about that, and too frequently these terms are misused. So if I was going to talk to you about a multi-state outbreak of infection, that most likely would be it would be either an epidemic or a pandemic. If it was restricted to a certain region, then it would be an epidemic. If it crossed the country, it would be a pandemic, but by no means would it be an outbreak. Now, an avian influenza outbreak among poultry occurring worldwide from time to time, and you know that what that is. That's a pandemic. Now, I'm not going to go through all these, but I want you to understand, and you ought to be able to classify them by the definitions that we just used. Okay, this is a little tricky, but it's a good exercise for you. And it says, and observed and expected tuberculosis cases, United States, 1981 to 1988, and you can look at the person, place, and time variables. But this indicates, if we follow the solid line up to this point, this would be the endemic state. This is what we would expect, because it begins to decline, so we assume that it's going to continue to decline. But instead, what happens, it takes a turn and it levels off. So the difference between the observed and the expected makes it an important problem, and this is showing you the cumulative number of cases that have happened that would not have happened if the decline would have continued otherwise. Now, the next thing we need to do is decide what this is. Is it an outbreak? Is it an epidemic? Is it a pandemic? And you know right away that when we talk about a country, a continent, or the world, we're talking about a pandemic, right? Because we're talking about the United States. So don't be fooled by the number of cases, and remember that we're looking for the observed to be greater than the expected. And usually we think about things um, in just the opposite. The trends are just the opposite as they're shown here. So to determine a pandemic, you must know the endemic state, and I'm going to introduce another term, a diagnosis. The cumulative number of disease is not always a giveaway. It has to be the spread of the disease over a large geographic region. But to be certain that we know what we're talking about, we have to have a confirmed diagnosis of the problem. And in each case, these would be diagnosed cases of tuberculosis. Otherwise, we don't really know what disease we're dealing with, and we don't know what conclusions to draw. Now, I want to talk about the fundamental assumptions about a disease, and these are two, and very important. And the first is that a disease does not occur at random. And we believe, otherwise we wouldn't be spending our time acquiring an education, that there's something that determines a determinant or an agent that causes a disease, and oftentimes these are preventable and controllable, um, so that the public can protect itself. Okay? Now, if we didn't believe that, again, the point is that we wouldn't have epidemiology, we wouldn't have medicine, we wouldn't have a lot of practices, individual practices or population practices, population-based approaches that focus on this particular issue. Now, um, I'd like to also talk about variables that we think are important in the influence of disease, and you can see these five that I have listed, and we're trying to get to determinants. By culture, we mean shared values, conventions, or social practices about behavior. And I mentioned the Deep South and ethnic backgrounds before, and we have a certain way of doing things, or we have customs and social mores. And oftentimes these can be very important. This can be a very important population determinant of disease. For example, a high fat diet that we talked about in the South. In society, really by that we mean a distinct group that collectively um, leads to a culture or societal conventions or wine with a meal, certain things that we connect based on societal expectations or events that occur. For example, going to a wedding, going to a baseball game. All of these are, or the Indianapolis 500, or you might consider consuming huge amounts of alcohol or blackouts, which are on the rise and also leading toward mortality in youth. And so I just share that society has expectations of us too that can have a very detrimental effect on our health. Um, we find that genetics plays a role, And if you're unlucky enough that your parents say suffer from high cholesterol, it may go on down the generations. Sometimes it skips one, but your grandfather had it, your father had it, you have it, your son has it, and the next generation below has the problem too. Well, that's pretty much a, a genetic, what we call predisposition to the problem, and likely you're going to have it and you're going to need to do something about it. So that's just a characteristic passed on from one generation to another, similar to eye color or whatnot, or body build. Now, environment. We're talking about physical, social, emotional factors, and you could almost call this wellness, because we know that we have 6 areas of wellness. Well, classically we have 6 areas of wellness, and that if you don't participate in certain things, that they have a negative influence on health. For example, if you don't exercise, um, you you're more of a couch potato, um, and other elements in our environment help diseases to flourish. And it could be in occupational health, or it could be in environmental health, where we're breathing certain toxins on a regular basis. We could talk about radon, and that's a different use of the word in environment. But so we have environmental things that we can do to make things better, our diet, what we eat, and physical activity, and then we have environmental elements that for example, pollution, that are detrimental to our health. Now, where we're leading to determinants, and determinants, another word for it is agents, and there are, we usually look at determinants to have to do with something having to do with demographic variables. And demographic variables I mentioned before, for example, age, gender, race, religion, devoutness, etc. Okay, so we know that in some cases, those factors alone seem to be help to identify what is causing, because the determinant is looking for the causal link between a disease and how it occurs. Okay, now, and we go right back to looking at the prior chart. So let's ask the question. We talked about the gray area, and we talked about the cities, and we talked about person, place, and time, and we talked about distribution. And we can take all of those variables that we just talked about. We can talk about culture, we can talk about society, we can talk about determinants and demographic factors, because what we're trying to do is identify how we're going to focus, because we know that we can't spend money on everybody, because we have insufficient amounts of money to concentrate on the total population. So you'd have to make priorities here, and this would probably be done by the Centers of Disease Control after looking at this map, and you can see the source, and we know who we would be concentrating on. So those factors, and that we know that disease isn't random, that's the assumption. Therefore, this is how we would begin to focus. All right. And you could use your terms that you've learned. Is it an outbreak? Is it an epidemic? Is it a pandemic? Well, we know it's a pandemic, don't we? Because it crosses the U.S. So there's another distribution term that you can use to describe it, along with person, place, and time, and all those variables that seem to influence disease. Okay. So the second keyword is determinants. So when you go back and look at that definition of epidemiology, we're looking at determinants. And determinants are variables that affect the distribution of the disease. And these are all things that influence the distribution of the disease, and they have to do with person, place, and time. So a determinant, again, implies a cause and effect relationship, as does predisposing factors from the social sciences. When they're looking for a determinant, they call it a predisposing factor, but you um, see that um, we're using determinant when we talk about epidemiology. Okay. Now, um, so not all of these factors in red go together. That are always they don't always appear together, but for the sake of what we're trying to learn, we're trying to identify determinants. That's a primary goal. Then we're trying to identify risk factors. That's the second thing we're looking at. What are you doing or what's going on that puts you at risk? And then what are the risk factors? Okay? And so this is the purpose of a determinant. And it's very important that you understand the connections and the interrelationships between a distribution and what it does, a determinant, and risk factors. Okay. We talked about risk factors and their examples, behaviors. We know about cigarette smoking. We know about physical inactivity. We know about not wearing a helmet when riding a motorcycle or a bicycle. Um, we talked about environmental exposure, air pollution from staleys, wet corn milling facilities, loud music or noises, for example. Human characteristics, and that could have to do with genetics, but it could have to do with age and gender, race and ethnicity. And we looked at that. We said that if it was wholly endemic, that it influenced kids. So there's an example of a distributional factor having to do with age that would make you more susceptible to a particular disease. Now, can you think of any others that examples of risk factors? I'm certain that you can. I've just covered the surface here. Okay, frequency. Finally, in this definition, we've come to the definition of epidemiology. We've come to the third term. And all of frequency means it's a count. And what we're going to do is we're going to count people. That's the primary thing that we do in epidemiology. We count people. And frequency helps to tell us about the magnitude of the disease, how big the disease is. And we saw that by looking at the maps that I showed you before. So the concentration of the darker colors indicates a greater magnitude of the problem because we have greater numbers of people in those areas of concentration that have the problem. And frequency also tells us whether we have an outbreak, an epidemic, or a pandemic. And we want to look at trends and patterns that lead to hypotheses about cause, prevention, protection, control, treatment, and intervention strategies. So frequency is a very important component, and all three are needed before we can make a difference. Especially, we're looking at this from a population base because we want to impact as many people as possible, and we want to protect the public's health through prevention and control of determinants that affect morbidity. So I've tried to use as many epidemiologic terms to describe what it is that we're trying to focus on. And I'm encouraging you to learn that vocabulary as I'm demonstrating so you can talk in an epidemiologic way. Now, here's an example of, of frequency. If we're looking at crude injury mortality rates in males by level of economic development. Okay, and you can see this is a gross national product, and you can see the countries across the way. Now, when you look at the rate, you notice that you're going to draw some conclusions. And what are you going to draw conclusions about in terms of crude injury mortality? Where is it happening? Where is it not happening? So if you look at the high areas according to rate alone, you're gonna conclude, well, Sri Lanka is high, right? Um, Egypt obviously is not, according to rate. And if we look at some of these other countries, Mexico is high, and you notice that these countries are not. Now, what would you conclude from that? Is Sri Lanka a thriving country in terms of gross national product? According to this, not. Is Egypt? No. Is Thailand? No. Is Chile? No. Is Mexico? No. Is Argentina? No. And where we have higher gross national product, we have lower mortality rates amongst males in crude injury mortality. So you can see the relationship between these two trends in terms of crude injury mortality rate. As you know, we're still dealing with frequency, and I want to bring that out as we look at these recent events in U.S. history and how frequency helps us determine whether or not we're looking at a outbreak, a epidemic, or a pandemic. And I want to make some comments about this particular chart. All of us dislike war, and we talk about the number of people that are lost in modern history in terms of war. And for example, I think I mentioned that the Civil War was the most deadly war of all time in terms of modern wars, and that we lost 600,000 people. World War II, we lost 200,000 people. In Vietnam, about 57 to 58,000. But at any rate, what's been more significant in terms of the loss of people have been infectious diseases. And so when we look at frequency, and for example, influenza in 1918, this was a real holocaust to our country. Actually, this time frame should probably be 1917 to 1919, and approximately 20 million people were killed worldwide, or 1 to 2% of the population. If you look at all the wars in the history of the world, we've never had anything that has been that lethal ever. Now, when I look at these, like St. Louis encephalitis, this is always misleading because you think, well, this particular disease is probably restricted to St. Louis. Well, that simply isn't the case. If you look at the Control of Communicable Diseases manual, you'll find that it just doesn't work out that way. And really, this is happens to be, of course, I mentioned, if I didn't, that influenza was obviously a pandemic. And St. Louis encephalitis is a pandemic, even though the numbers, there's only 1,815. So that's why I keep telling you, don't be misled by the numbers as an indication. Numbers are only one thing, but we want to take geographic spread or geographic location into account as well. And with St. Louis encephalitis, we find it in most of the United States, Ontario, Trinidad, Jamaica, Panama, and Brazil. And so that's why it would also be classified as a pandemic. Now, Legionnaire's disease in Philadelphia is a very interesting situation. It's where Legionnaires attended a conference and the ventilation system um, was contaminated, and as a result, this was in 1976, it was restricted to a single location and a single hotel, and there were I don't know, I think there were a little over 200 or 300 people in attendance, and 182 were affected and 29 died. Now, we're always looking at the observed over the expected, and in this case, the number who died was far greater than 2, as we had indicated, and the endemic state being 1. So this is an outbreak, is what I'm trying to explain and define to you by the criteria that I've shared with you earlier. Now, Lyme disease. Lyme disease is a little harder to determine, but one of the clues is from 1982 to 1992. You have a prolonged period of time, and this again, the numbers are not near what influenza might be. But we have here 49,872 cases. But Lyme disease is concentrated from Massachusetts to Maryland and in the upper Midwest, in Wisconsin, in Minnesota, and in California, in Oregon. So geographically, again, it's covering a broad area, and it's covering the totality of the U.S. So in that case, it's a pandemic, and again, because of its geographic presence in terms of the continental United States. AIDS is, you're not going to have trouble with that. You can see the time period, and obviously 315 is a high number, and AIDS is, we've made improvements, but we still do not have that disease under control, as you well know. And so if we looked at incidence, the incidence of new cases is still occurring, but it's a pandemic because it is spread all over the world too, and as you know, it started in Africa by the bite of a monkey, and then it made its way across the ocean. But the one I haven't mentioned that I think is really important was the Black Plague between 1347 and 1350. And in that case, 1 in 4 people died in one of the worst natural disasters in history. In 1352, it wiped out 1/3 of the world's population, or about 25 million people. It continued to spread death off and on for the next 30 years. It started in China with infected rats, and the disease killed in just mere hours. It didn't take very long for someone to die. So I hope I've made the distinction. There's two factors that you want to take into account: observed, over expected, or endemic state, and then you want to take into account geographic region. And this has to do, we also look at the frequency of the disease to make a classification in terms of the observed over the expected. So I hope that's clear. Now, let me give you a summary of what we've studied, and this is a definition of epidemiology that I want you to commit to memory, because if somebody, it organizes your thinking immediately, because it covers the key concepts that we're going to focus on in epidemiology, and it helps with classification and the utilization of all kinds of other terms that correspond. As you know, we spent a lot of time on distribution, and the distribution and the frequency are used to identify determinants of the diseases. We're looking for causes of diseases, and we're trying to narrow it down to a univariate cause. Most often it's a multivariate cause, and that we're focusing on injury and disability, and we're focusing on both of those concepts in human populations, not animal populations. Animals are important, and that's why epidemiology is taught in veterinary medicine, because we realize is about 70 to 75% of the diseases are spread from animals to humans. And then we have entomology to make up insects and the impact of the insect community on diseases and the spread of diseases as well. Okay, so what terms have we covered? We've covered epidemiology, we've covered distribution, we've covered outbreak, epidemic, and pandemics, determinants, and frequency. And at this point, you ought to have a pretty good idea about how all of these go together.